So David, today we have a 27-year-old male who presented to the emergency department with urine retention.
Okay, thank you, Joseph. So, urine retention in a 27 years old male. As usual, when Joseph says it's a short case, that diagnosis will be very difficult to get. But I'll try. And of course, considering that urine retention is not exactly just a urological diagnosis, but then it's something that automatically many times if someone presents with urine retention, they will likely, if it's in a setting where there is a specialist, they will a urologist will be consulted. But when you talk of urine retention, I think I do not have a very good schema, but I think of some issues. So one, of course, it could be something very structural, like a benign prostate enlargement, which of course in a 27 years old male is very difficult to think about. So another thing is a urethral stricture, for example. So that is for structural issues, and there are many others. So for example, if someone has a bleeding diathesis, they bleed into the urinary tract and then they have a clot, it can also lead to retention. So anything structural, that will be one big umbrella which contains a lot of things. But then another one is the urine retention could be something that you do not have something that is structurally obstructing the urinary tract, but it's more neurological. So uncontrolled contraction of the sphincters leading to inability to pass the urine, or failure of the detrusor muscles to contract in order to force out the urine. So it could be neurological. I think those are the bigger categories that I'll put right now, although they are very arbitrary. I would say structural and then something that is purely neurological without a structural obstruction. And of course, when you talk of the second category, I think I'll also consider some medications, although I'm struggling to get some medications right now, but I think I'll get some as time goes. So let's hear the history and then see. But overall, I think I'll have a hard time here.
Thank you very much. So let's see the HPI. So this patient reported that 4 days ago, he woke up in the morning with back pain, and he attended another facility on the same day, and he did some blood and urine tests where he was told that he had a UTI and he was given medications. So he had no urinary symptoms whatsoever initially. The back pain improved with those medication. On the next day, he developed urinary frequency, dribbling, incomplete blood emptying, and he reports that he would feel a full bladder, but when he went to the toilet, he produced scant urine, and would do this multiple times of the day. On the night of admission, he woke up with a painful full bladder and went to use the bathroom, but no urine came out despite pushing hard. Denies a similar episode prior. He denies constipation, fecal incontinence, lower limb neural symptoms, or erectile dysfunction. He denies painful urination or urethral discharge. The behavioral system is unremarkable. Past medical history, he recalled an episode of a gonorrhea 2 years back, which was treated, but he denied any urethral instrumentation prior to this episode. And family and social history, is married, has one child. His father and mother and siblings are all alive and healthy. Yeah.
Yeah. So although I'm having a difficult time to figure out what is going on, but I'm very interested to know what was the case resolution in this patient. So let's start from the beginning. That 4 days, let's say prior to presentation, he presents with low back pain when he wakes up in the morning, and then he's told to have a urinary tract infection and given medications. So that that chronology of events there could sound helpful, but uh, it can actually be adding another layer of complexity. Why? Because with someone who presents with lower back pain, you could think that the urine retention that is presenting with is neurological in origin. That maybe the patient is having a compressive myelopathy, for example, a compressive myelopathy which is presenting with the urine retention. But then in that case, you would expect to also see some symptoms, other symptoms, because what we are seeing here is that the patient does not have any sensory symptoms, does not have any motor symptoms, does not have any other autonomic symptoms. Because so commonly, although my recall maybe of the presentation would not be 100% perfect, but then with autonomic presentation, someone who presents with urine retention or incontinence, at the same time, most likely they would present with also fecal incontinence or fecal uh, or constipation, for example. So these symptoms would commonly go together. And then in this patient, yes, we do have some presentations called Equina syndrome and others, but then there would be some sort of sensory symptoms uh, and probably motor symptoms that hopefully when we come to examination we'll see. But at least from the history, I am not seeing any of those other symptoms that I'm talking about. If this was truly uh, something that has to do with the spinal cord due to the lower back pain. So the complexity I was talking about is the patient presents with lower back pain, and then which, because it's reported that it started when the patient woke up. So my assumption here is that it's something that is acute. It wasn't present initially. But then he's given some medications. Joseph, let me see the previous slide. He's given some medications. Now, so the medications are allegedly meant to treat a urinary tract infection. And I think this is something common that we encounter when we see patients. Some patients will come to you and tell you, I think I have a urinary tract infection. And you ask the reasons why. They do not give you the typical symptoms of whether a lower or upper urinary tract infection. They tell you, I have lower back pain. So there are patients who equate lower back pain with, uh, with the urinary tract infection. We have not heard of any symptoms, whether dysuria, any other symptoms prior to what has transpired here. Now the patient presents with lower back pain, is given some medications. So I know for sure that there are some medications which can cause urine retention. There are medications which can cause urine retention. Now, can I think of because uh, my assumption is this patient was given antibiotics. Now, do I know any antibiotics that can cause urine retention? I'm struggling to find any. But so my thoughts here are this urine retention could be associated with the low back pain, although I'm struggling to establish that because I do not see, I'm not seeing a compatible syndrome here, a presentation of other symptoms which are closely related to that, as I discussed earlier. The medications that were given could be another issue. Now, so the patient reports improvement in the lower back pain, but then he develops symptoms which are they sound to be obstructive lower urinary tract symptoms, obstructive slash plus some irritative, because there is urinary frequency. Although frequency, of course, itself can be an obstructive rather than irritative symptom, because if someone is not emptying the bladder completely, then they'll have to go back to the washroom many times. So that would translate to urinary frequency, not because of irritation as in cystitis, but because of incomplete emptying. And then there is dribbling. So dribbling is an obstructive symptom. And then incomplete bladder empty. And so this patient feels a full bladder, but he goes to the toilet, just can't urine, and this happens multiple times, and it keeps happening. So can I see the next slide, Joseph? But what this could translate is, so the patient, the bladder is full, but then he does not pass all the urine, so he retains urine. As I said earlier, it could be one of those two things, and I think I'm oversimplifying here. It's either the detrusor muscles are not contracting fully in order to empty the bladder, or the the sphincters are spastic. As spastic. Now, thinking of the dribbling and all that, I mean, it could be any of these, and I think this is where I need to improve. I think I'll need to go and improve on my approach. Is that can these symptoms tell me what exactly is the problem between the detrusor muscles and the sphincters? I think that is something that I need to improve on. So, and then, of course, when the bladder is full, definitely it will be painful because of stretching. So this is because of stretching, and then the patient tries to push hard, but then nothing is coming out. He does not report any prior episodes, and then no these other symptoms that I talked about, especially autonomic symptoms, constipation, fecal incontinence, and motor as well as sensory symptoms. Erectile dysfunction is another autonomic symptom. And then it does not report painful urination or urethral discharge in the current presentation. So something that is significant in his past medical history, I think, is the history, and he sounded very categorical. I know in our setting, it's hard to isolate, although we could conclude based on epidemiology that maybe this is a gonococcal infection, because that is the commonest. But many patients will present with a urethral discharge syndrome, and because we do not do nucleic acid amplification tests or any other tests to exactly isolate the organism, we treat syndromically. It could be anything, gonococcus, it can be chlamydia, which are the close ones. But so let's say he had a urethral discharge syndrome 2 years back, and then of course, based on base rate, it's likely to be gonococcal. And this was treated. Yes, although it was treated, there are complications. There are complications like urethral stricture, as I said. But then, so because I have not been dealing with urology for a while now, I think my previous knowledge is also flying away bit by bit. But so presentation of a urethral stricture, I think this is rather very sudden. Although because of the history of urethral discharge syndrome years earlier, I think I'll have to keep that in my list of differentials. Although because of this presentation, which is rather acute, I'm struggling. And initially, maybe I think the hazy memory that I have is the patient would report of painful urination, at least initially, which was not there initially in this patient. I think those other symptoms came later. And I do not remember if painful urination was, I think it was not there actually. So the bladder was full, and that is when pain came in because of stretching. So there is no element of pain. And then he denies urethral instrumentation prior, which is another risk factor for urethral stricture. So I think up to this point, I'm just having a list of differentials, but the history which I rely on many times to at least get an idea of what is going on, I think I still have some questions. Yes, urethral stricture, I think one of the differentials, although at this point I would say maybe not very high on the list. I'm still interested to know the medications that the patient was given and to see if there is any element of those medications causing urine retention, and then the lower back pain that the patient reported, and whether it is related to this whether it's related to this presentation. So let's go to physical examination. I'll see if I can make any progress.
Thank you very much, David. So much learning from you. So, general exam, patient was alerted oriented. He was in distress because of pain. He was a febrile, not pain, not jaundice, no lower limb edema, didn't have lymphadenopathy. His vital signs, normal blood pressure, was tachycardic, 108, temperature was normal, respiratory rate normal, and he was starting normal in Rumea. Systemic exam, per abdomen, he had a tender suprapubic distension. The neuro exam was normal. Other systems were also normal. A urinary catheter was inserted and it went in smoothly, and 800 cc of urine was collected. Suprapubic pain and swelling resolved. Oh, okay.
Yeah, thank you, Joseph. So this is what I was waiting for. So physical examination. So in settings like this, actually, part of your physical exam and interventions it's like part of the diagnostic tests that you are doing. So this is something that I wanted to say uh, prior to hearing this physical exam, that one of the things that you definitely want to do is to try and insert a urinary catheter and see what happens. So when you put in a catheter and it goes in smoothly, uh, that in some way narrows your list of differentials, because if it was a urethral stricture, you definitely struggle to insert that catheter. On the other hand, of course, with BPH plus or minus, it can go in smoothly or not, but then especially with the urethral stricture, you would struggle and maybe also see more trauma in the patient, which you are not seeing with this patient. So with that itself, I'm not completely ruling out a urethral stricture, but I think I'll put it very low on my list of differentials. And now think that this patient's presentation was not because of a urethral stricture. Was it because, and this is where again I'm struggling, I think I'm having a gap in knowledge, that what if it was the sphincters that were not relaxing? Would it also be difficult to insert the catheter or not? I think Joseph will teach me this later. Or is it a failure of the detrusor muscles? So I think I still have questions, so the neurological exam is helping me in a way. So a normal neurological exam, meaning this patient does not have something like, and when you are testing especially sensation, you also need to test the perineal area in order to see if this patient has had anesthesia, for example. That comes in one of the syndromes. It's probably Cauda-Equina syndrome. Joseph will remind me if I have forgotten anything. So neurological examination is normal, which means this patient doesn't have a sensory level, doesn't have limb weakness, doesn't have sensory abnormalities anywhere. And then So with abdominal examination, yes, so maybe this was done, maybe not, but a DRI is also can also be helpful. Although, because we right from the history do not hear constipation, we did not hear fecal incontinence, less likely. So uh, physical examination again has ruled out some things. So, for example, something in the spinal cord that is a little higher, ruled out. A urethral stricture, I think, to a large extent, ruled out, but at least because of my gaps in knowledge, I'll still keep it, but very low on the list. But apart from that, I think I've not been able to make much progress. So now, what would help me make progress? I think to know the medications that the patient has used in order to see if there is any medication that will ring a bell as a cause of urine retention. And then, of course, apart from medications, so anything new that this patient consumed, whether it's an over-the-counter medication, these medications that were prescribed, of course, it will be very hard, for example, with herbal medications, to know a full list of herbal medications that would cause urinary retention. But I think medications would be important. And then apart from that, would an ultrasound help me make progress? So an ultrasound, what it will tell us is, so this patient will be given fluids. Maybe you block their catheter, of course, take it out, and then they are given fluids. You do your ultrasound. You, of course, I think it won't help much to measure the pre-void and the post-void because the patient had retention. So another thing that I was thinking of is prostatitis, for example, which can happen with anyone, inflammation of the prostate. But then with prostatitis, there would be some presentation that this patient would report. Of course, lower back pain is part of the story. But then another presentation is these patients would present with perineal fullness or pain in the perineal area. That is a presentation of prostatitis that I know. So with the prostate being inflamed and swollen, I think it would present in a presentation that is similar to BPH, but then I'm not seeing those other symptoms. As I said, perineal fullness, lower back pain, of course, is part of that story. So another thing is if it's very overt, patients with prostatitis can actually present with fever, which you have not had in this patient. So I think prostatitis will be part of the differentials that I'm considering. Of course, physical examination has not helped us. So with this, when you do physical examination, they will present with perineal tenderness, which we did not hear. So I think that is another thing I'm thinking about. But Joseph, let's see the investigations that you have, but still tough.
Yeah, that's a lot of progress. Investigations, nothing much. FBP was normal, MRT was negative, urine analysis was positive. We're having a leukocyte +1 and protein +1, but no blood. RBG 5.3, A1C 4.7, CREA-B1 were within normal limits. And this, okay, they also did a KUB, which was normal, but I think there was no pre-void.
Huyo ni nani?
Okay, let me mute this
I
one.
think, David, you should mute someone.
Yes. Now let's proceed.
Okay. Yeah, so they also did a KUB, but I think they didn't do the pre-void, post-void. There were reasons, but it was essentially a normal KUB, and I think this is the end of the case if you have any diagnosis.
Okay, this is tough. So with Of course, the other labs we did not expect much. So what we are seeing is you say leukocytes +1, and then protein +1, which are not very dramatic. Not very dramatic. We did not expect anything in that other presentation. Of course, doing a glycated hemoglobin and RBG were important because diabetes are one of the things that we can quickly think of that can present with neuropathy. Although we, including autonomic neuropathy, although we would expect this patient to have much more presentation and a prolonged course to the point of causing this. So what is going on in this patient? So for anyone who, if there is anyone who joined late, Joseph has been presenting a 27 years old male who presented with a day or a few days history. I think like a day or two of urine retention that was preceded by lower back pain, which was treated with antibiotics, presumably because of a diagnosis of a urinary tract infection. And then afterwards, the lower back pain improved, but then he presented with initially more of obstructive lower urinary symptoms characterized by urinary frequency, dribbling, and then incomplete bladder emptying. But then afterwards, the patient presented with complete urine retention with a distended suprapubic area, pain, but he did not report any irritative urinary symptoms like painful urination or any other. Of course, if we consider the frequency to be also obstructive. So physical examination, apart from suprapubic tenderness and distension in that area, other systemic examination was unremarkable. So general examination, the patient was in distress because of retention. It's a tough experience, and the tachycardia, of course, because the patient was in pain. Otherwise, nothing. So what is significant is a past medical history of a gonococcal infection 2 years prior. But the patient was treated, and then during examination, a urethral catheter is inserted, and then it goes in smoothly. So a KUB ultrasound being normal, so KUB, it's kidneys, ureters, as well as the bladder. So what I know is that in a KUB, they also report on the prostate. So the KUB being normal, is adding another layer of complexity. So I talked about prostatitis as part of the differentials, but then so I believe if the prostate was swollen and was inflamed, they would likely see something. So which was not seen here, but still, because of the presentation of lower back pain, as I said, an incomplete presentation. I did not hear those other things that I mentioned. So prostatitis and mild improvement with antibiotics. Of course, prostatitis, these are normal antibiotics like amoxiclav that are given, could be, but then the organisms can be a little different. Although the slight improvement, should we say it was prostatitis that was improving? But again, prostatitis, when we talk about it, part of the story is it's a complication of the STIs that we normally talk about, and this patient did not present with a current urethral discharge syndrome. So Joseph, I think I do not have a diagnosis. I just have a list of things, and if you ask me any other thing that I would do, I think in this patient, all I'm remaining with is to review the medications that he took. And then because the antibiotics, if you ask me to think about medications that can present with urine retention, they are more psychotropic medications. So medications that are given for depression, like tricyclic antidepressants, they can do that. and so can medications like pregabalin and others. So they are more psychotropic medications. I do not have a comprehensive list of those medications at the back of my mind. So if the patient mentions some antibiotics, I think I'll just go online and see if the given antibiotics could present with that. I think that was the only thing, that is the only thing that I'm remaining with, reviewing his medications. Otherwise, otherwise, as I said, prostatitis, I think that is another thing that I'm considering. Although a KUB ultrasound, I think, took down my confidence a little bit. Urine retention, I mean, urethral strictures, I said, very low on the list because of the easiness with catheterization. So what I would do with this patient, I would review the medications, and then after reviewing the medications, of course, I would try and establish really, because all we are seeing is leukocytes 1 plus, and then protein. There was no blood, which would commonly present with STIs, for example. So what I will do is review the medications, and if I do not find any good reasons for a diagnosis of a urinary tract infection, try to stop the medications, and then take the catheter off and see if the patient is if the retention resumes. So that is a desperate measure due to lack of a diagnosis. So I think those are the few that I have, but otherwise I think the likelihood of missing the diagnosis here is very huge, and therefore I'll just sit back and wait to learn from Joseph. So back to you.
Thank you very much. The likelihood is very, very minimal of missing a diagnosis. So yeah, your assessment is more than correct. That's what also we did with my fellow doctors. So he wasn't sure the meds that was given at another facility. We asked his wife to bring the meds to hospital, and it was amoxicillin and tramadol. And for me, this was easy because I've seen another case of a woman with urine retention because of tramadol. I said, okay, it's tramadol. I've read about it before. So we thought it is the one which was causing the retention, and we stopped it. We also stopped the amoxicillin because this tendency in this country of saying everyone has a UTI because of urine showing leukocytes, I don't know where it came from, but I think maybe we poorly teach our fellows, young doctors. Yeah, so the amoxicillin, we also stopped it because we didn't see that this patient has a UTI, also being a male. We removed the urine catheter the next day, and he voided normally. So we canceled him to avoid tramadol in the future, plus or minus any other opioids, if that will be possible, because of what the literature also says. If you have one tramadol, you can have one other opioids. Yeah, so that was the case, David. That was a correct assessment, but it wasn't antibiotic, it was tramadol, which was given for lower back pain. The reason why also in lower back pain, tramadol is not something which is you should give. You start with PCMNSA first, and maybe if no response, you do even physiotherapy. So let's have some learning point about acute urinary retention, because we have a chance. So this is the most common urological emergency. The incidence increases with age, and it's most common in people above 60. Extremely more common in males compared to females. And as you know, because of things like prostate and strictures, you need to intervene urgently, because you should avoid complications like loss of bladder contractility in the future, UTI, renal dysfunction, post-renal, and urine incontinence. Etiology, the most common would be bladder outlet obstruction due to, in males, things like BPH, stricture, constipation, bladder or prostate cancer, and others. But in females, you can have cystocele, rectocele, pelvic mass, anything coming from behind and obstructing the urine passage. Neuro diseases also, like cord diseases. That's why David was trying to rule out any neuro symptoms. diabetes, stroke, they can also cause urinary retention. Meds, a lot of meds are implicated, but the most common are anticholinergics and sympathomimetics. But also tramadol is rare, very rare, but has been reported in other cases. UTI also can be the cause, trauma, and other causes. So here is the list of medications. This is, if you go to up to date, you can see it. So maybe a lot of medications here. So I just put them here. If someone wants the slides, I can give them. They can check them on their own time. So the treatment, you have to do a prompt catheterization unless there's a contraindication. And contraindications include if there's a pelvic trauma or a pelvic surgery. And if there is stricture, if you suspect there is a stricture. For this, we didn't do that because, okay, the doctors who admit this patient, they thought maybe the patient has stricture, but 2 years is not enough. If you see patient with stricture, they're usually somewhat a bit older than this 20-something. But and if there is no any suspect that there is stricture, then you insert your own catheter and it will go in easily. For medication-induced urinary retention, you stop the CAP medication and you avoid the medication in the future, as we did in this patient. Any reflection, David? Nice job. You got the diagnosis right.
Thank you, Joseph. So, as usual, when Joseph says this is a short case, that case will not let me have peace. So, urine retention and a number of differentials there. So, remembering medications, I think, is something that would be far-fetched in most patients. And so, of course, one thing is the ones who took care of the patient, including Joseph, that was a job very well done, because otherwise, I think maybe others, if the clinicians were not very keen, would have said, okay, this is the patient reports a history of a urethral discharge syndrome, so this is urethral stricture, and settle with that diagnosis, and probably the patient would continue with his medications, and the narrative would continue. Although now maybe the reality would come after the patient has finished taking those medications. But otherwise, I think a huge learning exercise for me, because there are those complaints or syndromes for which you are very well prepared because you come across many times. You have well prepared schema, but so for this, you see, it's like you are building a plane while flying it, because it's been a while, of course, seeing patients with urine retention brought specifically to a physician. So, but I think what this underscores is one thing, that uh, having a broad approach to patients is something that we need to have at all times, because if it was someone who was triaging this patient and head of urinary retention and not ask themselves and think this is a 27 years old male, they would say, okay, this patient should see a urologist. But any clinician, of course, who pays attention, I think, uh, like the clinicians who saw this patient, would be able to establish what is going on. So thank you very much, Joseph, for adding, of course, the list of medications that can cause that. This was a huge learning for me, and I think there's a number of things that I need to go and take care of. So thank you very much. We still have some minutes, so if there is anyone who has anything that they would like to add, so the chat was active. I didn't see some of these, but I'm told he said cauda equina syndrome or prostatitis. Thank you very much. And then Libason, DRI was indicated. Yes, very, very correct. I think DRI was also, so in a patient who presents with urine retention, something that is also important to see what exactly is happening. So anyone who has anything, any comment, anything that you'd like to share experiences in order to cement what we've learned today, if you've come across such a thing, before we close, because we still have some minutes. So if you have something, you can just raise your hands, or you can just unmute and speak. Please welcome. Japhet, do you have anything?
Oh, no, no, sorry.
No problem. Yes, Dr. Mondolela, please welcome.
Okay, thank you very much for a very nice test. Well presented, well argued, and well discussed. Um, and the approach to reaching diagnosis has been very systematic. I don't have much experience with opioids, like low potency opioids like tramadol causing acute retention of that kind. Though of course it causes rarely, but I still have some reservation as to whether this was the actual cause of retention to this young man. We have not been told exactly how much was the dose and for how long. Of course, the man went with symptoms and they thought it was UTI. I first of all don't understand why in UTI you give tramadol, the dose of which I'm not very much sure, and the duration of the dose. Was it strong enough to cause acute retention? If actually it causes. So I was still discussing myself and see whether this is the final and correct diagnosis in terms of the strength and the duration of the dose. If anyone also has a concern, you can brainstorm and get solution to this, please. Thank you.
Thank you very much, Dr. Mondolela. I see Jacqueline here has something. Jacqueline, if you're in a place where you can unmute and share your experience, I've seen your text in the chat. Please welcome. Jacqueline, are you in a place? So Jacqueline sent a text in the chat that she has seen a patient with penile retraction from taking tramadol. So uh, uh, probably she's not in a place where she could speak. Uh, I think this would be an interesting experience to hear, maybe in a summary and what transpired after any interventions that were done. And Kelvin has something here that patients with detrusor muscle dysfunction would present with painless retention with little or no urge to urination and overflow dribbling as compared to one with sphincter dysfunction. Thank you very much, Kelvin. I think this is, yeah, so this is one of those things that I said. I think there's a gap there. I had a gap there that distinguishing, can I distinguish clinically between someone who has dysfunction of the detrusor muscles as compared to someone with sphincter dysfunction. So detrusor, Kelvin tells us that the retention would be painless and then overflow dribbling. Thank you very much. So I haven't seen Jacqueline unmuting. Probably she's not in a place where she can speak. And I do not see any other hands. So if there is anyone else before we close, please welcome. Yeah, I do not see any other hands. So just a few reminders. So for So for those who have, Sizwe, do you have anything? Please welcome if you have anything.
Yeah. Thank you so much, Dr. David and Dr. Joseph, for a very nice presentation. I think my concern is from the extension. It's just an extension from Dr. Henley. If whether this type of acute urinary retention is dose relating to tramadol. For sure, this is the most commonly prescribed medication among the opioids. So it was very important to give chance to Dr. Joseph to highlight whether there is a matter of dose relating and the frequency of the tramadol given, so that we could be much more cautious whenever we prescribe tramadol to patients. Thank you.
Thank you, Sizwe. So Joseph, if Joseph has the details, Joseph, do you have anything on as a reaction to both Dr. Mwandolela and Sizwe?
Yeah, so the dose in that patient was, which means 100 TDS, two tabs TDS. But the literature, so no dose relation. It's like a certain medication, patient one gets the side effect or complication vis-a-vis patient number two who doesn't. So that's why it's a patient specific. In patients like this, we tell them do not use this medication in the future, because you will have something like this again. And if it happens, then you increase your conclusion. But I get the point of Dr. Henry that should we think of any other thing? But look at it. What else has David really well dissected this case? Because when you have urine retention, is the neural thing from your brain, spinal cord, and everything to the detrusor muscles and sphincters of the blood outlet. No any other symptoms except at the bladder only, and you stop the medication, patient urinates normally. When the patient was using medication, wasn't urinating normally. By the method of elimination, you say the medication was the culprit, unless there is something else which I personally didn't see. And being my second case, I didn't struggle. Thank you.
Thank you very much, Joseph. So yeah, I think so. That's what sometimes, as I said earlier, sometimes some interventions like the insertion of the urinary catheter was also diagnostic, meaning you rule out some things, because if it was a stricture, you definitely struggle to do that. And then stopping the medication, and the patient does not return with urine retention, increases confidence. And of course, this is something that as clinicians we always have to deal with. That it's actually very few times when you are 100% sure of a diagnosis. Very few times when you are 100% sure of a diagnosis, but anything above 90%, 92, 90, how much, based on your history of physical exam, and maybe you've done some investigations, and sometimes interventions as part of the diagnostic process, that increases your confidence in the diagnosis to a certain level. So this is good food for thought. I think we'll all go and do some reading, and maybe when we meet here next week, if any one of us will have come across something else that would probably better explain this patient's presentation, or another thing else that will be that is worth considering or elevating into the list of differentials for this patient, I think that will be very very good learning for us. And that brings me to my, yeah, Davis, I see you have a hand. If you have anything, please welcome. You can just unmute and speak. I'm not sure if that was if you have anything, Davis. I'm not sure if that was accidental, if he has anything. So if you have anything, please, you can just unmute and speak. Yeah, so my other message is the message that we've always been doing here. So you can see Joseph's case today is that it was a short case, yes, very challenging because as you can see, we are still pondering on whether there is anything else that better explains this patient's presentation. But then it was a short case, and then we had something to learn from it. So I know that because you people see patients, you come across many interesting patients that many interesting cases that we can learn a thing or two from. So please do not second guess that maybe this case is not interesting enough, is not difficult enough to be discussed. So we are not here to discuss difficult cases. We want to discuss cases that we can learn something from and become better at diagnosing and the entire spectrum of management. So right from diagnosis, patient approach, to management and follow-up of patients. So please bring those cases so we can learn from them. Otherwise, we are just on time. So if there is nothing else, it was good to see everyone here and some senior colleagues here. So Dr. Mwandolela, very good to see you. And I think I saw Professor Nyagori also in the chat. So thank you very much, everyone. Good to see you, and we hope to see you again next weekend. Have a good night, everyone.
Good night.